Alright, so for this next lecture, we're going to talk about the ECG here on Casual Sunday. One of the biggest kind of, I'd say, modes of contention in the OR is placement of the ECG patches, because it's pretty non-traditional setups, depending on, where the surgery is happening. If you're having surgery in here, all this area is getting prepped, kind of affects where you place it. Also, kind of positioning of the surgery, if they're on their side, and when you have to flip them completely on their stomach and prone, then they're on their back. So kind of a lot of things to consider. A couple of things too, just from my personal experience, that it may or may not affect you, is keep in mind, for years, depending on how long you practice as a nurse, you put these things on several times, but it was always like on the side and not from the perspective of the head of the bed. So that kind of changes things. Sometimes it can throw off your equilibrium of left and right. Also too, especially at first, is those adhesives really stick to your gloves, and it's kind of a pain in the butt, and everyone's telling you to like speed up, and you're constantly having to snap back. So we're going to go over the ECG, kind of the important things to highlight here. I'd focus mainly on, like, if you're going to watch this lecture, it's like slide 90 or 94. It's kind of the reference ones that shows you all the points, the P, QRS, ST segments, things like that when we go over. The P wave is the atria, so electrical activity kind of correlates to force of contraction, so obviously the QRS is much higher because it refers to the ventricle, and the P wave, which is just the atria, so relatively smaller. For the next of the conduction pathways, I would say for the ECG, not important to know, but for depending how competitive of an anesthesia student you are, as far as knowing the Thorell tract and Wenckebach tract as far as the SAAV node, and that the Bachman is the right atria to the left atria. That's more for like anesthesia trivia and just trying to prove how smart you are. So this was mentioned, I guarantee, in the cardiac lecture. Einthoven's triangle is the basis for placement of pretty much, here on the heart, here, kind of no matter where you put the leads at first, it's just being sure that it's kind of in the center of at least 3 leads as far as the perspectives that you're looking at, that it's capturing the heart. So the QRS complex, it gives you all the stuff for the P wave, how long, the QRS, so on and so forth. The T wave, important, so the midpoint of the QRS to the peak of the T is absolute refractory period. So going back to when you first did the neuromuscular lecture, as far as action potentials, the absolute refractory period is no way, no how are you going to go through repolarization again. Now peak to the end, peak of the T wave and the end of the T wave is relative refractory. So with enough energy, so like when you went over in the hazards lecture, trying to avoid electrocuting yourself and electrocuting the patient, that if it hits at that point with enough energy, then you can send them into VFib. It's a PR interval, ST segment, QT, QTC. QT plays a little bit of a role, more so I think in like ICU critical care as far as you looking at that. QTC to see is just corrected, so it's corrected as if the heart rate was 60, but that's more like drug effects, like if they're on the SSRIs, kind of some of the dopamines. Also we saw that, not like you'd have to worry about, but like COVID patients, the hydroxychloroquine and azithromycin, seeing the extension to QTC. The main concern for you is the ST segment. And this is where we kind of start getting into like lead placements and what is most diagnostic. and why it's important as far as where these are. So the ST segment, slide 98 here, measured in reference to the isoelectric line. So if you place these leads differently, different configuration, you throw off the isoelectric line and it can give you an ST elevation when in fact that there isn't. Just because of how the ECG monitor's calibrated and where you place them. So degree of elevation depression is the isoelectric line. So it's the kind of the line here. I mean, I'm sure you've seen ST elevation depression at some point in your nursing career here. But in this picture perfect QRS drawing, the isoelectric line is kind of a line all throughout there. And some use like the TP line because of the P wave and the T wave all across. Mainly is the ST junction, which is the J point. So for testing purposes, J point, ST junction, isoelectric line. Because inaccurate placement gives false positives or false negatives. And we don't want that. Placement considerations went over depending on positions. That's why when you're doing those care plans the night before, having an anticipation of where these leads are going to go. Obviously not on any bony prominences, things like that. Not in the operating field. We don't want to get pressure breakdown in an ECG patch. Then you have a couple of references of what the actual 12 lead placement is. In right A, RA, right arm, LA, left arm, right lower extremity, left lower extremity placements. And this is next couple just references as far as what V1, where they're placed at in 12 lead, but importantly, based on where they're placed, the viewpoint you're kind of looking at the heart. Obviously, you're not putting 12 leads on these people, not in the OR. So the easy lead, you can get 12 lead derivation from the easy lead. It's what we used in the hospital. Sometimes it's not really practical because of where the surgery is occurring, especially getting your gallbladder. I mean, that green's going to have to go somewhere else, different. The different electrode placements. So, usually the thing gets discussed about is what lead is most diagnostic for seeing ischemia. And this is one of those that just seems like you're always going to be wrong for some reason, even though like you're sure like that's what that PowerPoint said, that's what that study said. People will shoot you down with such confidence. So that's why I pulled a couple studies in here. So the 2002 Landisberg study I pulled in to kind of define it. I looked at the American Cardiac Association, what they define it as, and looked up to date as far as studies that they have done. You notice that the answer is different on every single study. So one of those where you say something and they'll get a funny look, and it's like, where did this come from? Kind of know where it came from too. So Landisberg used 185 patients going vascular surgery, so high-risk patients, more likely that there's going to be a problem. So in that one they found, so we're looking for ischemic events, mainly showed as ST depression. So that is why the isoelectric line and establishing it correctly is important. V3 was most diagnostic, V4 was second, and V5 was third as far as one of the primary leads to look at. You have 5, but you can kind of program, you got 2 shots to look at, 2 lead placements to kind of get a look at it. So 97% of ischemic events in this study showed ST depression. Also mentions if you combine V3 and V5, 97.4 for detection versus V4, V5 at 92, or V3 with V4. Among patients in whom an MI developed, hopefully that doesn't happen, combining leads V4 and V5, or V3 and V5 was 100% of the mark. But what is done, and if you can get done, is everyone should have a 12-lead ECG, especially if they're going under general anesthesia, at some point recently, especially the high-risk patients. So, referred to as fingerprinting is you take the 12-lead, if any of the 12 leads show any ST segment changes in V3, V4, V5, like whatever lead was most sensitive, that is the primary lead that you will use during the OR. Also, what can be done is, there's a lot to kind of think of, especially when you're first starting through induction, but when you begin, put it on, part of the induction is to print an ECG strip before you induct them and give them the drugs. Therefore, that if something happens during the case and you didn't print a pre-op strip or pre-induction strip, you may not know, is this because of lead placement? Does the lead have to get moved? Is the surgical assistant kind of leaning on something which is kind of throwing off? Is the position a little bit different? Is this why I'm getting the alarm? Or is there a difference from after putting them to sleep that they're kind of having a reaction to this? Maybe having demand ischemia from it. So you print out a strip before induction so it's there, rip it off, tape it somewhere that you can see, and then if any question occurs later, then you put another one off, and then you can kind of compare pre-induction to during surgery. So ST segment J plus 60 milliseconds, 1 or 2 millimeters above and below. So that's what the AACN recommends. So the other one, the AACN ST and ischemia elevation. So if you don't have any acute coronary syndrome and no fingerprinting, leads 3 and V3 are suggested for you to use. Without definitive acute coronary syndrome, but you suspect, they recommend lead 3 and V5. So kind of an older, potentially person or a heavy smoker, doesn't see the doctor that often, blood pressure seems high, there'll be all the markers there where you kind of suspect that they don't have it now, they're going to have it here in the near future. V5 also useful for demand ischemia. So when you put them to sleep, you kind of put their heart rate down and their blood pressure down, and you're kind of messing with their vitals here that they're not used to. They can get demand ischemia. 70 to 90% of MIs detected with ECG are clinically silent, so it's not like they're gonna clutch their chest here in the middle of the surgery. So going to up to date, so a third resource, the Anesthesia study, the ACN, and up to date, they recommend leads 2 and V5, not lead 3. Lead 2 for the arrhythmias, which most of our kind of patients were always lead 2 as the primary in ICU. Single lead sensitivity, was V5 on its own versus the other Anesthesia study, which was third place, took the bronze in that study, but wins the gold in this one. Lead 2 with V5, around 80%. Lead 2, V4, V5, so you can get 3 leads on there, 96. And at that time, another study that was conducted for most sensitivity, V4 was most sensitive. So pretty much, depending on what study, it's either V3, V4, or V5, depending what you're referring to. So you can see why there is always a disagreement about what is the most sensitive lead for monitoring ischemia. So, all over the main points here. So the main point is the ST junction, the J point, the isoelectric line. Ischemia is what we're looking for. Most likely ST depression. Lead, varies as far as what is most sensitive. But the main point is fingerprinting. Very important in your clinical practice.